start. After one day in the morning of lectures, learning all the basic skills, it's time to put all the skills together into a system of examination. The first one I'll talk about is blue protocol. Blue protocol, the word blue comes from the fact that the patient is dyslip, and therefore they are blue in color. I was thinking whether blue stands for something, but actually it did not. Blue protocol is developed by Professor Liechtenstein. I'm sure some of you have met him before. In his 2008 paper, he did a study on a series of patients in the intensive care unit. And based on the type of patients, he looked at all the lung signs and decided to say that certain lung signs can help you diagnose a certain condition. There are some special situations about this. Number one, they are critical care patients. So they are a bit different from emergency patients or even ambulatory patients that you see in respiratory clinic and so forth. Secondly, he excluded all the patients with 2 or more pathology. So if someone has both heart failure and COPD, he took them out of the study. So he's looking at very pure conditions, single condition. This is described by Liechtenstein a bit later, a few years later when he wrote a new book. He believed that in order to do the blue protocol, there's a very simple way to examine the lung in a few locations. You need not scan the entire lung, but a few locations. So he developed this, what we call blue points. So his blue point is a good estimation by putting the 2 hands together without the thumb. And based on that, these markers are upper, lower, and a blue point. And the little finger will mark the phrenic line, which he says is the level of the diaphragm. So he said that this is quite good for a person between 1.65 meters to 1.85 meters. So I think this works based on his observation that all these people of different heights, you can use this level of estimation. But I think about it, this first point is roughly the 2nd to 3rd intercostal space in the mid-clavicular line. And this one is about 4th or 5th intercostal space in the anterior exterior line. So it's roughly that. Okay? So he said by using these points, you can actually do a good study and come up with a conclusion. From there, the upper blue point and lower blue point onwards, from a phrenic line, he says if you move your probe from there all the way to the mid-X-ray line, you should actually see what they call a phrenic point. The phrenic point points to the most lateral part of the lower lobe. So that's what his description is. So we are effectively examining different lobes of the lung to come up with a conclusion about what's happening in the lung. Then there's one more point, which is the flaps point. Okay? The flaps point is actually the extension of the lower point all the way until the posterior X-ray line, or even further. If the patient, if you want to study more, you can even ask the patient or make the patient turn to study deeper at the back. This corresponds to the lower lobe of the lung. He called this the posterior lateral alveolar pleural syndrome. Okay? The reason is he has described small consolidation that usually present in the posterior and lateral position in ICU patients because they're lying down all the time. So he observed that. And he says that you can diagnose flaps in this area. So these are the few points. This is one system of examining the lung recommended by him. To understand the blue protocol, you must understand all these terms. A profile means when you examine the front part of the lung, what you see is mainly lung sliding and A-line pattern only, nothing else. Okay? So this is A profile. So if you put a prime there, that means lung sliding absent. B profile means that you see many B lines. And bilateral, that means both sides, you must see both sides. B profile. B prime means, again, absent lung sliding. AB profile means one side of the lung has B profile, the other side has mainly A profile. That means no B lines on the other side. For him, he used the word C line. C equals to consolidation. So this actually refers to consolidation that's detected at the front part of the chest. Okay? And flaps is actually another kind of consolidation, but because it's on posterior position, he gives it a special name, flaps. Okay? Nuke profile means you don't see flaps at all after studying the lower part. Whether you see A line, B line, doesn't matter, but you don't see that. So this is a the way he used all the different terms in the blue protocol. So what do we look for? Earlier on I talked about the different positions to study, right? So upper blue point, what you look for is really on lung sliding, whether you're B profile or A profile, and or any consolidation, C profile. When you move to the side of the chest, the lower blue point, same thing, you look for this. Then you move your probe all the way to the phrenic point, which is the most outer part of the lower lobe of the lung. It's lung sliding, B profile and C profile, and of course the lowest point, flaps and diffusion. Okay? These are the main focus of Liechtenstein's blue protocol. So based on this, when we look at the lung, this actually, if you look at it, is a thinking process. After you examine the lungs on both sides, then you ask yourself, what am I seeing on one lung versus the other lung, and so forth. So if lung sliding is present, that means the lung is in contact, the two fluids are in contact and they are moving. Then you ask yourself, what kind of profile are we seeing? In this breathless patient, is an acutely breathless patient, if you see B profile, which means bilateral B lines anteriorly, in his study it's almost always pulmonary edema. And I'm sure you've seen that in your practice also. Pulmonary edema is usually almost always not one-sided, right? So it's very, very, very extremely rare, unless you talk about re-extension of a pneumothorax or so forth. So if you don't see any B lines or very insignificant B line, just A profile, so you're actually dealing with a patient with relatively clear lungs in ultrasound terms, then you must ask yourself whether this is a case of pulmonary embolism causing the acute breathlessness. Okay? And he will recommend that from there you should actually go for a DVT compression, a venous assessment. If the vein seems to be free, then you will go on to study the lower part, the stage 3, which is the most posterior part, to look for sources of consolidation that will tell you that, okay, this patient is breathless because of a pneumonia that's happening at the back. So if there's no flaps, you conclude that most likely you're dealing with exacerbation of asthma or COPD. Okay? If you have a mixed profile, A profile on one side, B on another side, or you can see consolidation in front, almost always pneumonia in this practice. Okay? I'm sure you've used a lung ultrasound in patient pneumonia. They've evolved from B lines, small consolidation, big consolidation, if you observe it over time. If the person has abolished B lines, that means, lung sliding, right, that means the pleural is either not in contact or is stuck down. There's two reasons why it's abolished. And you see it's B profile, B prime profile, that means this pneumonia. That means no lung sliding, but yet you see a lot of B line. This is due to an infective process where exudate caused the two pleural to get stuck together. So you have no lung sliding. If you don't see any blue profile, then you must ask yourself, am I dealing with other situations, example pneumothorax? Okay? And in order to confirm a pneumothorax, you have to hunt for the lung point. You know what's the lung point, remember? It is a junction between a normal lung and the pneumothorax side of the lung. Okay? And if you find it, you are very sure it's pneumothorax. Without the lung point, then you have to figure out, using other methods, what you are dealing with. No lung sliding, A profile, but yet you can't find any lung point. It could be a very large pneumothorax. It could be other reasons like pleural disease. It can be a non-lung ventilation. It can be other reasons. So you have to use other methods. Okay? Now, one thing that's not stated in his paper but in his book is that you should tie your blue protocol to what you have. You can only interpret all these signs together with history, physical examination of patient, plus some of the basic tests. He advocated that this must be done, and also some of this study must be followed by a very simple cardiac examination. So again, I think in our these few days of discussion, when we say we examine the lungs and all that, it cannot be done alone. Usually you should examine the heart as well, so you can make sense of what's causing the breathlessness of the patient. And beyond this, of course, he said that, if you have no choice at the end, they have to go on to more high-power investigation and arterial blood gas and so forth. Okay? So what are the practice points? I think in your practice, if a person is breathless, it should be the first step in investigation because it will help you start the plan very quickly. I've given an example for a patient with ischemic heart disease with COPD in one patient. If they come in breathless, and when you see B lines, you know that this person at least have a heart pulmonary edema. If it's clean, then the breathlessness is most likely to be due to just the exacerbation of COPD. So it's a very good way for you to start your management. There are some things to consider about this protocol. When he say blue point, actually if you read carefully in his book, it doesn't mean exactly a point. So these are good way to start off in a very simple way. But you find that you can't see very much or you're not very sure, you can actually move sideways or examine the whole area. So it's not exactly a blue point. Okay? Another problem is that if you use the blue protocol without thinking about the patient's clinical clue, you'll be lost. And the third thing about this protocol is that this protocol is done on patients with single problem. So I'm sure in your practice you will see patients with mixed problem. You have pneumonia to get pulmonary edema, pneumonia and other things with pulmonary embolism. We have seen mixed pictures, so be careful of that. And of course, some of the profile is located in one area of the lung but not seen in other areas. So this will affect how you use the blue protocol. Okay? And other than lung scanning, you should proceed to other type of scanning if it helps you in the process of managing the patient. Okay? So this is blue protocol in the simplest term.